We are going to record the session. So welcome. My name is Kate Gleason Bachman. I use she, her pronouns. I am the Clinical and Quality Improvement Nurse Manager here at the National Healthcare for the Homeless Council. And I'm a registered nurse, and I'm located in Philadelphia, Pennsylvania. And I'm just going to get us started and kind of orient everybody a little bit to this session. So this session is on assessing and addressing health management in healthcare for the homeless and in medical respite settings. And we'll talk more about what exactly that is and how we can all apply it. But I'll just start by saying this is something that both Caitlin and I are very passionate about. This is a real interest of ours from both of our clinical practices. And so I think that will come out throughout the session, but this is quite important to us. We have the chat open. You can ask questions in the chat as we go along. We'll try to monitor it. We are going to have some time for questions at the end. And if something comes up that's pertinent to what we're talking about, we'll try to jump in and answer any questions that we can. So feel free to put questions in the chat throughout. The other thing I'll say at the beginning, and we'll revisit this again at the end too, is this webinar is related to a publication that we have coming out very soon that's on this same topic. And so that will be available to all of you, and we'll make sure you have information on that at the end. So with that, I think I'm going to turn it over to Caitlin to introduce herself and get us started.
Great. Thank you, Kate, so much for getting us kicked off here. I'm Caitlin Sinovic. I'm our Assistant Director for Medical Respite here at the Council. I'm also an occupational therapist. That's my clinical training and background. And as Kate mentioned, I'm very passionate about the issue of health management and how we can support folks with that, both in our health centers and in our medical respite settings. So before we dive into the content for today, we do want to start off with a land and labor acknowledgement as part of our practice here at the Council. So although we are all here together today in a virtual space, we are all interconnected by the land beneath us. The communities where Kate and I reside include St. Petersburg, Florida for myself, and Philadelphia, Pennsylvania. So we're going to take a moment to recognize the Seminole, Timucua, and Miccosukee tribes and the Lenni Lenape tribes, and honor with gratitude their unceded lands and their people past and present. We also honor the brilliance and humanity of all immigrant labor, including voluntary, involuntary, trafficked, forced, and undocumented peoples whose labor remains hidden in the shadows, but contributes to the well-being of our collective community. By recognizing the land that was taken from first Americans and the forced labor that was provided by enslaved Africans and Black and Brown people, we strive to take steps towards creating a more equitable and just world for all of us. So if you're interested in learning more about your own land acknowledgements, you can go to nativeland.ca and look up the original land bearers of your location and learn more about your community that way. And very much encourage you to do so.
Thanks, Caitlin. So I'm just going to talk a little bit about our agenda and then our objectives for this session. So today we are going to define health management and talk about what it is. Think about what health management means and considerations for supporting people with health management in healthcare for the homeless and medical respite settings. And then we're going to dive a little bit into recommendations for how to assess health management. So how we might do that informally and formally using tools and just our clinical skills. And then we have a couple of case examples and time for Q&A at the end. As far as our objectives, by the end of this session, attendees will be able to define health management and explain why it is important. Folks, we hope that you will understand how experiences of homelessness may impact health management. And finally, we hope you'll understand how to apply formal and informal health management assessment tools. Next slide. This is just a disclaimer. This webinar is made possible by funding through the Health Resources and Services Administration. However, the contents don't necessarily represent the official views of nor endorsement by HRSA or the U.S. government. Next slide. Okay, we're going to move into an overview, and I'm going to turn it back over to Caitlin.
So before we jump into kind of the how do we assess health management, we wanted to make sure that everybody is sort of sitting in the same place with what we understand to be health management. And one of the reasons that we have an entire resource now dedicated to this, as well as this webinar today, is that health management is really complicated and complex, right? We say health management as if it's one thing or one activity, but really it is made up of a whole bunch of different tasks and activity that somebody needs to do, that all of us need to do in order to manage our health. So when we're using the word health management, we're referring to the definition that includes any activities related to developing, managing, and maintaining health and wellness routines, including self-management. So this might include symptom and condition management, communicating with the healthcare system, which is a whole host of activities all on its own, medication management, physical activity, nutrition management, personal care device management, and then social and emotional health promotion and maintenance. So it's important to note when we say health management, we're not just talking about medication management, which I think is often what people will default to. Medication management is important and critical, but it is only one part, along with all of these other ways that one might manage their health.
And I think one way that we can conceptualize health management is to kind of think of it as all the things that people do outside of direct interaction with service providers. So like outside the clinic space, outside of respite, or within respite, but things that they're managing on their own. So things that people are doing on their own outside of the face-to-face interactions that they have with clinicians or service providers. So when we think of it in that way, we can kind of think about how experiences of homelessness might really impact all of these tasks. And as we go through these slides, you'll see many of the things that fall under the umbrella of health management are quite related to each other. And so how someone manages in one area really impacts how they might be able to manage or what their health outcomes are in another area. So thinking about experiences of homelessness, first and foremost, we know that folks experiencing homelessness often have to focus on their basic needs, or their basic needs are not being met, or they're at risk. So they do not have shelter. They do not have consistent access to food. They do not have a safe space necessarily. And so it's very, very hard to think about making it to your appointments, or how to fill your med box, or, you know, how to use your inhaler or using it twice a day, all the things that we might think about related to health management when you're thinking about where your next meal is going to come from, when basic needs are not being met. So this already is compromising how folks are able to manage their own health. Similarly, around self-assessment and decision-making for folks whose basic needs are not being met, who are wondering where they're going to stay, or are staying somewhere that's not safe, or who are chronically spending the day on their feet. They have a lot of chronic pain. They have multiple chronic conditions that are going on. It can become very hard to kind of make an assessment of what their own condition is. Is it something that's becoming acute? Is it an emergency? Kind of how do we make decisions, or what is the right choice around when it's time to seek care or go to the emergency room, or any number of things kind of within that spectrum. And so it can become very, very difficult when you kind of have a baseline where health needs are not being met, where basic needs are not being met. We know appointment management can be hard for folks because they don't always have access to a phone. They don't always have access to a calendar, public transportation. People need to show up to appointments with a whole lot of things like their insurance card or referral, understanding of why they're there. And so that can be really challenging. Medication management can be challenging for a number of reasons. Sometimes this has to do with the fact that folks are carrying all their medications. Medications can be stolen. There can be physical challenges around actually having the dexterity to fill a medication box. People may be staying in a shelter space that they need to leave during the day, and so they don't have access to their medications for midday dosing. So there can be lots of things around medication that can be impacted by experiences of homelessness. We know that stigma and provider bias really impacts the care that our patients are getting throughout the health system. Previous bad experiences around other healthcare providers with stigma can make people not only not want to access care at all, but when they're in care, feel uncomfortable disclosing things that they are struggling with. So if they're having a challenge managing their diabetes, or they don't have the dexterity to screw the insulin needle tip on their insulin pen, you know, they're worried about playing into the stigma that they have faced in the past, and they don't want to say that they're struggling. And so this can really be an issue with communication. People can also feel nervous about speaking up for themselves, for self-advocacy, because of bias that they have experienced in the past. And finally, use of durable medical equipment. This also can run the gamut. Lots and lots of different things qualify as durable medical equipment. This could look like folks who are staying somewhere where they don't, maybe their bed in the shelter is not near a plug, and so they can't plug in their CPAP. Maybe they have issues with having refrigeration available. They can't refrigerate their insulin. For folks who use durable medical equipment like a cane or a wheelchair and they're on their feet or they're outside all day, that equipment can wear down much, much quicker than it might in other settings. And we know for insurance purposes, that can be an issue if you need a wheelchair, every 2 years instead of every 5. That's a whole big thing. So these are all challenges that people face around experiences of homelessness.
So now we're going to jump into what does it mean to assess health management and what can this look like across different programs?
So in terms of how to assess health management, I really think about this as like a process of exploration. This is kind of some of the, I feel like, more fun work we get to do as we really get to know someone and kind of dig into how do they see their own health? Where are the places that they see themselves struggling? Where are the places that we, as a person working with them, might see that they're having a hard time, or they're not having the outcomes we might anticipate based on the plan of care that they have? And so this is like an investigative process, and a cycle, and we'll talk more about exactly what that cycle looks like. But health assessment, it's a process. It involves the systematic collection and analysis of health-related information, for use by patients, clinicians, and healthcare teams to identify and support beneficial health behaviors. So what this really means is we want to use our clinical skills in whatever kind of area we work in. And I don't just mean, like a nurse or provider. I mean, whatever is the area you're working in, you have the ability to kind of drill down with someone and figure out what's going on, what are the challenges, what are the ways that we can help you to better manage your own health. And then we may also use tools, which we'll go into later, and some assessments that may be formal or informal to kind of figure out what it is that's going on. And this cycle, this can really impact how people see themselves. So a big part of health management is what people's self-perception is, kind of how they see themselves as having control over their health and control over their body and the ability to manage their own health. And so by supporting people in this way, we can make a big difference in terms of people's confidence in their outcomes. If someone has a successful experience with learning how to use an insulin pen and they feel like they can manage their diabetes and they, can take on other health goals, that's a very different experience from someone who doesn't understand how to use the pen, isn't able to express to anyone that that's happening. No one investigates it. And they are kind of pegged by their provider, or someone feels that they're not trying, they're not managing it, it's not working. And so that can have a big impact on how people feel about their health in the future. So this is quite important as we kind of enter this cycle and do this investigative work to figure out where we can support people. So these are some areas to think about as we're kind of diving into what skills we might be evaluating for folks around health management. One of them is health literacy, and this also includes numeracy, so the ability to kind of understand and manage numbers. And that is also an area that folks can have challenges in. So this obviously impacts people's ability to take their medications, to understand why they're going to a provider, to understand what their own diagnoses are, reading instructions, all the things that come along with the many, many tasks that go into managing our own health. Medication self-management is another area where we might be evaluating folks, in terms of their ability to know what time of day it is, to understand why they're taking the medications that they're taking, potential side effects, to understand what to do if they miss a dose. Do they know what to do if that happens? Do they have the dexterity and the ability to fill a medication box for themselves for the week and to know what day it is and take the pills in the order that's intended? So those are all related to medication self-management. Physical skills for health management also might include filling a medicine box, taking your blood sugar, taking insulin, knowing how to use your inhaler. There are some actual physical tasks that people need to do that can be challenging. Time management is a large category, not just around taking medications, but also getting to appointments. Being able to judge how long it's going to take to get to an appointment and how to get there. Self-advocacy, we talked about a little bit. This can be hard for folks, especially if they've had negative experiences in the healthcare system, and they can have some fear around disclosing that they are struggling with something, that they don't understand something, or speaking up and saying that they don't agree with a plan, or that, they don't feel that their needs have been heard. And then finally, we talked a little bit about self-assessment and decision making for folks. This can be hard when you're kind of living in a constant state of distress and trying to meet your basic needs. And this is also a skill set for people to know what are the symptoms I'm looking out for that mean that something is an emergency or I need to call my provider. How are decisions made around, when to go to the emergency room versus to call your doctor's office? When can it wait till the next day? All of these things that kind of go into navigating the healthcare world and our own health.
So as Kate mentioned, we kind of recommend or come up with a process around assessing health management. And one of the things that we didn't mention at the beginning, I wanted to point out, is we're using the term provider in the context of this webinar and in the publication. And really, when we say provider, we mean anybody that is providing support or engaging with the client. So I think, it's not just a physician or a prescribing provider or a nurse, but really anybody who's engaging and supporting the person. So as we saw with those health management skills that we're going to assess, there might be different roles for different members of the team or care providers, right? In terms of self-advocacy and self-efficacy, that might fall into a different, different folks might be addressing that or supporting use of those skills. So the process that we've identified here, we've displayed it as a linear process as 1, 2, and 3, but it doesn't have to be linear, and it isn't necessarily linear. I think we often know that building rapport and comfort with the folks that we are working with is really sometimes doesn't go in the order that we might imagine. Ideally, it'll start with a discussion with the client just in order to identify their own priorities around their health, what is important to them, what are they experiencing right now, what are the immediate needs, but sometimes an opportunity to observe the environment or assess what the person is doing, that might pop up first. All of these are really important pieces of the health management process. If you only are able to do one, the discussion with the client is really the priority, right? Because we can assess anything and everything all we want, but it doesn't matter if we're not reflecting what the person's priorities and needs are at that moment in time. And a lot of folks present with a lot of different complex things happening at once. We might not be able to do everything all at one time, and it might just be this iterative process of tackling one really emergent issue and then circling back and starting this process over again around a different health condition or health need. So a lot of this, although we're kind of talking through what the process can look like, really will also require a lot of clinical reasoning from you around what is appropriate, what is the person accepting of at this point in time, what's important, what do we have capacity and resources to be able to do and to be able to address at this moment. So just keeping those things in mind as we're talking through it, we're going to talk through it in a linear way to help with learning and understanding, but knowing that this is going to look very differently depending on what setting you're in and how you're engaging with the folks that you're working with. The other thing that we are going to talk through here is around using standardized and non-standardized assessment tools. So standardized assessment tools are those that have been developed to evaluate a set of skills, knowledge, and behavior. And these are structured, validated assessment tools. That means that you're delivering the assessment the same way across all clients. So there's going to be a set of instructions that you're going to follow in order to administer the assessment, score the assessment. Usually there's guidance around interpretation and scoring and norms around what we might expect to see based on this person's age or gender or whatever it's normed against. The benefits of using standardized assessments is that they've been tested, so they're valid and reliable, so that the information that you've gained, it can be interpreted consistently, and you can compare it to the larger population. It kind of helps put in context what someone is or is not able to do to say, is this a minor problem or is this a significant issue that we're going to need to address? So all of that is really great to say, and if you're a research person, you're like, yes, standardized, that's great. Someone tell me what to do and what to look for. The issue with using standardized assessments in health centers and medical respite programs is that the majority of them are not inclusive of people experiencing homelessness when they are developed for a lot of different reasons. And, some of it is discriminatory, some of it is challenges with the population. This is not a population of folks that people prioritize research on. And so that the instruments themselves may not be fully applicable for the people that you're working with. There was an assessment tool that I used that wanted people to write checks and do different tasks that people maybe hadn't done in years. Those things were not relevant to what they were doing in their everyday lives. So it was hard to administer that in a standardized way. A standardized assessment tools also may not include people who have complex conditions, because that makes it murkier when you're trying to establish the validity of an assessment. And so even they may not be inclusive of people who have had a stroke or a brain injury along with their cardiovascular condition. Those folks might not have been included. So that's really important to consider, just because when they're not tested appropriately on these particular populations, the results that you get may not be accurate. So if they're not tested with folks who education level is below 12th grade, somebody might demonstrate that they are having difficulty or challenges in a certain area, but it's not because of the task that they're asking. It's that the questions are too challenging for somebody or not at the appropriate reading level. So it takes a little bit of judgment, again, on your part to be able to decipher and identify, did the person score lower on this because it isn't a skill that they know, or because the language that's used isn't applicable to them. So just a few things to consider around standardized assessments. Non-standardized assessments are tools that generally have a structure but are flexible in administration. So these work really well in our health center and medical respite settings because they allow us to be responsive to the client. We don't have to follow a certain pathway in order to gain information. We can adapt to base on the person, what we know, what their life experiences are, what your needs are as a provider, and what information you're gaining. So non-standardized assessments haven't been tested, so they're not necessarily valid, reliable. You don't necessarily get the same results every single time. And it's hard to place it in context, but it does get a lot of information. So I think there's always a tendency to look for something structured and standardized, like what tool can I do to do this? And we really want to empower you as providers to trust your skills and your judgment, because there's a lot of information that can be gained from conversation, from things that aren't as standardized, especially within the settings that we're working, where we have to be flexible and do things differently than the rest of healthcare anyways. So, the downside is you can't necessarily compare somebody's performance over time or to each other when you're not doing a standardized assessment, but it does allow kind of some openness and flexibility. So when you're doing all of that to say, when you're deciding what to do or what assessments to do or how to approach that, just a few things to remember: that you'll want to follow your own scope of practice and use clinical reasoning to determine what tools you want to use to assess health management skills. There are a bunch of things out there. There are a lot of ways to go about this, but we don't want to spend 4 visits with a person assessing them and never actually getting to the healthcare, right? Sometimes when we're with folks, we need to assess and develop a plan of care and respond to that plan of care all within the time that they're with us, because we may not see them again very, in the near future, or because there might be some really immediate concerns. So all of that's going to play into what you decide to do and how you decide to approach it. Regardless of what you choose to do, kind of based on the information we provide today, all assessment practices should be client-centered and integrate the client's healthcare priorities as much as possible. So you may opt not to do something that you know is going to be beneficial because it doesn't fall in line with the patient's priorities. They might really emphasize needing to manage pain before they're able to address anything else. And it's important to respond to that because that is part of rapport building. And if you want to ever assess anything else or address anything else, they're going to need to trust you and recognize that you have their needs at heart. So just as a reminder through that, we're going to provide some recommendations around process and how to do this, but it'll sort of be up to you to decide what that looks like within your practice.
So I'm going to talk a little bit about actually kind of discussing with the client all of these areas that pertain to health management. And thinking about kind of how do we ask these questions to get into this information and to find out what's going on. So this is the part I mentioned that's like doing some exploration or some investigative work that I really like. And I think this is just such a fascinating and fulfilling part of working with folks who may be struggling in these areas. You know, you can find out a lot by just asking people, you know, what their own goals are. How do they feel about their diabetes, or how do they feel about a particular health condition? And then diving a little deeper and finding out how they are managing it or kind of perceiving their care around it. Um, in general, when we're talking about kind of asking these questions, you really want to try to stay away from asking people questions that are very simply answered or yes, no questions, and try to move more towards open-ended questions that are really going to elicit some information. And this I can say, you know, I have been a nurse, I think for 16 years, and it has taken me many years to kind of develop the questions that I know tend to work with people. And I've had many, many times where I've asked a question, and as someone is answering it, I realize like I did not ask that question in the best way. And so sometimes you'll kind of tell from the response, like, you know, I need to get more information from someone. For example, it's much different to say to somebody like, how are you doing with your meds? And the person might just say, great, but they're actually not taking their meds at all. You know, similar to when someone says, you know, how are you? You just say good automatically without necessarily thinking about how you're actually doing. And so a lot of those kind of short questions, people answer them very automatically. It's much different to say to someone, you know, tell me about how you take your medicines every day. And so I often find it's useful to kind of think about starting things with tell me about, like, tell me about what happened when you went to the hospital last week. Tell me about how you feel about this, you know, new diagnosis or whatever the case may be. And that tends to elicit a lot more information. And we'll talk more about observation, but the other piece of kind of having someone tell you about something is actually watching them. And so having someone show you, just saying like, okay, show me how you usually take your meds, or, you know, tell me how you keep your medicines organized at home. Tell me what you do if you miss a medication. And that tends to kind of give you a lot more information. So a lot of these things we have kind of covered, but motivational interviewing, we're not going to dive deep into what this is, although happy to provide resources on that. But it's a great way to kind of elicit more information from people and to help people explore what their own feelings are, particularly if they have some ambivalence around kind of how they're addressing it, a healthcare area, or they're not quite sure how they want to proceed. That's a great way to kind of help people follow a path and figure out what it is they want to do. It's quite client-centered. We want to find out about what people's perceptions of their own health are. People's attitude about their health and their health conditions really has an impact on how they're able to manage them, or their perception of their ability to manage their own health. And so that can make a big difference. As Caitlin mentioned, we really want to make sure that we are centering people's own priorities and health goals. You know, as clinicians and service providers, this can sometimes be difficult because people might want to start in a different place than you would start. You know, what they see as the top priority might not be what you assess to be the top priority. But it is important to start where someone wants to start. The impact of someone setting a goal and being able to achieve it, a goal that they set themselves, is huge. And that often can set them on a path of being able to then achieve many other things. If they start with a goal that they're not even interested in and they're not hugely successful with it, that can set them up to really struggle down the road. So I often remind myself that, you know, even if we're not starting at the same place, we are usually all traveling in the same direction. And so that helps me to just kind of say, well, we're going to start here, and we're going to kind of catch what we can along the way. And a lot of things can get accomplished like that. We want to find out if people have concerns about health management activities. Is there an area that they have identified where they're struggling, or where they feel confused, or they're not sure if they're doing the right thing? Assessing their current knowledge of their health conditions, of how they are supposed to be managing them, kind of what instructions have they received and how do they understand those? What do they think they're supposed to do if X, Y, or Z occurs? Talking about the things that they're currently doing. And some of this can be assessment, and some of this can really just be encouraging someone to recognize all the places that they are managing their own health. People can sometimes feel really disempowered. They don't feel like they have control over anything. They feel like they're very sick, they're not doing well, and it can really help to kind of bring someone into understanding like you're actually doing a ton. You're managing your appointments. You made it here today. We're addressing X, Y, and Z. You're doing all these things that are actually quite complex, and that can help to someone to feel better about doing adding other things or just kind of pushing along on the path that they're on. And then I'm going to pass it over to Caitlin, who's going to talk about more about kind of tools that we use and standardized assessments.
Yes, and one thing that we should mention before we kind of dive into observation and all of that, the publication, the resource that we're putting out details all of this information for you, so you don't have to remember everything from today. It also includes a table of standardized assessments that might do some of these things we're talking about, including these, getting the discussions with the client and understanding the client, as well as the observation piece. And there's also some of those recommended questions that Kate and I have honed over the years around, tell me about, what does this look like for you? That you can use that and integrate what might be helpful within your practice there. So the second task really around, you've had your discussion with the client, you've identified, what the goals or priorities might be, both for yourself and the care plan and for the client. And observation of skills, I think, is a really critical component that goes a little bit beyond what might normally happen in a healthcare interaction, but can be really crucial and critical to figure out what somebody's barriers might be. Folks sometimes have a hard time articulating or talking about what is challenging. They just know that it is. And it also can be just really helpful to see like where there are gaps of information happening, like little things that you can pick up on as a provider. So you might not be seeing the person in the place where they're doing their health management tasks. You might be seeing them in the clinic or like the medical respite program, and not necessarily where they're staying in shelter or in an encampment. But it's still really helpful to see kind of the steps and process a person might be going through. If you are a mobile provider or you're in shelter or a street medicine team, you may have the opportunity to see what the person is doing in context, which is even better, as much as possible. But as much as you can do, just having the person show you what they're doing can be really helpful. And so there's two approaches to doing observation. So, and we're going to walk through what those different approaches are and what that can look like. So there's the first approach is observation without interfering. So really what this means is that you're going to ask the person to do the health management task, and you're just going to observe. You're kind of going to be observing, standing by. I often tell clients, it's going to feel weird. I'm going to watch you. You might feel like this is strange or that you're being tested. I think it's great to normalize that for people because there's a lot of anxiety if they think they're being tested, and it might produce some errors, right? So instead, it's just like, hey, I want to see what you're doing so that we can figure out how to make this easier for you, or just to make sure that like I'm communicating well, right? Giving that preface, I think, can really help people feel comfortable and not like you're scrutinizing or judging them or seeing that they can't do something, right? Trying to approach it from a supportive way. So you'll ask the person to perform the task itself, and this can be any health management related activity. Often the example I give is around administering medications, just because it's so critical, and it's something that a lot of folks do, but it can be related to administering insulin. It can be related to using an inhaler, using durable medical equipment, putting on a CPAP machine, transferring from sitting to standing with your mobility device. It could be any health management related task, calling the pharmacy, anything that you can do. It doesn't just have to be around meds, although that's is a pretty common one that we might ask the person to do. So we're simply going to, set up the supplies that the person needs and say, do this like you might do it if I wasn't here. And then you're going to observe what they do. This is the hardest part as a provider, as a teacher, as an instructor. You are going to keep your mouth shut and you are going to let the person do. And you are going to just observe and see what happens. You want to let the person know that you want them to do it how they might normally do it if you weren't there, if there wasn't any supports available. As they're doing it, identify if there are issues that pop up. And it could be issues in terms of barriers of the skill of the person. It could be issues of the environment, right? If they're trying to call an outside provider to follow up on a referral, and that's what you're observing, and you recognize that the phone tree the person is calling is confusing or doesn't work, like you're going to note that down too. In addition to maybe the person, if they demonstrate difficulty following the phone tree or understanding or being able to use the phone to hit the button to get to the right person. Observe any barriers that you might identify, issues, things that pop up during that process. It'd be helpful to write notes or just kind of note in your head what is happening, because you want to then be able to support the person and do some instruction or teaching to do that. And then ideally in that moment, or if you're seeing the person really frequently, you might do a couple of follow-up sessions depending on your role and what type of provider you are, but provide education on the issues identified. Providing it in real time immediately after the observation is ideal because you want the person to learn how to do it correctly. If it's something that's more complicated, again, you might need a couple of additional sessions to be able to do that. You also want to provide opportunity for the person to practice. So if you're providing education and teaching, have them demonstrate what you've just educated them on and allow them to do it a couple of times so that they're going to be able to retain that, or provide some, follow-up resources and simplified handouts, or communicate with a community health worker or another provider, right? Making sure that whatever skills that you've taught the person is going to be able to use, or they have an opportunity to be able to do that. So this can be a really great way to just sort of get a clean set of like, this is what's happening outside of these appointments and outside of the time with the provider. It really works well when it's not something new to the person. So if you have just taught somebody how to use insulin for the very first time, this might not be the best method because they probably haven't practiced or retained the skill and are going to need some instruction as they're doing it. This is something that the person says, yes, I'm doing this, or I know how to do this, or this is something I've been managing for a long time. This does not work well when the potential for errors are going to have consequences. Please don't watch someone administer the wrong amount of insulin, right? There might be times where it's really a safety issue that you're going to need to interfere and either provide instructions or stop the observation. That's up to your clinical judgment, right? If somebody's calling the pharmacy and they're just like having trouble with the phone tree and then they hang up in frustration, that's not great, but there's no consequence to that versus, again, watching somebody administer or use something more incorrectly. So just being mindful about what you're asking the person to do, and that there might be potential that you'll need to step in to do that. And that's fine, right? That's part of the flexibility that we have in our settings. You also, again, want to avoid it if the person really has some significant memory issues and they're going to like remember the steps incorrectly. So again, that's why it's not as good with a novel task. Like you don't want someone to go through the steps and show you them incorrectly and you allow it to happen. And that's what they remember in sort of that motor memory. If it's something that they've been doing for a long time and they have memory related issues, then you can observe it because you already know that this is something that they've been doing, versus if it's new, you want to actually provide that instruction. So that's one way or method for observing. So you're observing, you're not interfering, you're, just kind of watching, seeing what happens. You don't have to do it that way. The other option then is to observe with teaching. And as this name suggests, you're going to see how the person does what they're doing, but you are going to provide education and teaching in real time. So very similar process, right? You're going to ask the person to perform the task as they might out in the community, outside of the clinic or the medical respite space, wherever you're meeting with them. And again, this can be any health management related activity. The difference between this method and the previous method is that you're going to point out when the person makes errors. So you're not going to just kind of sit back and watch and make notes from beginning to end, that you're going to, provide education when you see things happen. Let the person know before you do this so that they are expecting that, right? Again, people feel nervous within healthcare settings. They might feel like they're in a testing environment. So say, hey, I'm going to see how you do this on your own. But if something comes up, I might teach you, or I might show you an easier way to do this, or make sure that we're doing it correctly, right? Give the warning about how you're going to interact with the person there. As the person is going through and doing the activity, if you see something happen that's not correct, pause and then provide education on that. So if somebody's filling their pill box incorrectly and you're worried that they're going to remember that wrong, say, oh, let's stop and pause here. Let's check for errors. See if the person, recognizes that they put 2 pills in the slot. maybe they don't recognize it, point it out, say, hey, there's 2 in there. Let's reread your medication. This says 1, let's fix that, right? How much education and instruction you provide, again, is going to be dependent on the person. You might simplify it if it's somebody who's really struggling. You might say, hey, there's an extra pill in there. We're going to take that one out and move it here. Really, really direct. Or if it's somebody that you're trying to process through learning, you might provide less direct cueing and a few more details with there. So you're going to interfere when errors are made, and not let the person do it incorrectly. And then again, provide additional learning opportunities. Most of us need a couple of tries before we learn to do something new at any point. So if you're providing education and instruction, make sure that you do it again at another point in time and not necessarily embedded in like going through the whole task. So talk about insulin. I think Kate and I are going to talk about insulin a lot because it's hard to do in terms of administering insulin. You might identify and just have the person practice twisting the insulin pen to the right dose, like over and over again, just practicing that task to make sure that the person can do that in the way that you've instructed them to do it, instead of walking through each and every step of it. So when you do this observation with teaching, go from beginning to end of the task. But then with the areas that you noted you provided education, make sure that you do that again, and not necessarily all those steps together. So the benefit of this approach or method is that you're going to be able to correct the errors as they happen. And it's really critical to prevent anything that might be dangerous or have a negative impact on the person. The downsides of this, it can take a long time. Teaching around a complex health skill might take a little bit extra, and it's definitely going to take longer than if you're just observing the person do it. It's also, the person might be distracted from the task. If you're interrupting to provide teaching and education, they might lose track of where they are, not follow the steps in the same way, and they might not remember all of the education provided, again, because you're intermixing it in. So this is all to say there's not a perfect and true method that you should be following, but again, identifying what's going to work best for the person, providing education and teaching throughout so the person feels successful at the end of the task can be really great for people who are struggling with motivation and self-efficacy versus doing something and then being told, oh, here's all the mistakes you made. We're going to walk through that, right? If you're supporting and providing education so that they get done and they have a completed pill box that's correct, you can sort of celebrate that. And like, that was really hard. Great work. Like, we're going to keep practicing this together. That's going to maybe change how that person feels about that activity and increase motivation. So, knowing what the person is, who the person is, what their priorities are, it can really help inform which method of these that you decide to do. There are standardized assessments around observing people doing different health management tasks. As we noted, there are some benefits to doing a standardized assessment. Because it's structured, it's going to give you a set of instructions. You can measure change over time. They'll give you a score with it. You don't kind of have to make this process up or this checklist up for yourself. You can just follow that. The downside is that it's not going to use the person's own equipment or supplies. And there are some folks who really struggle with that. There's a medication management assessment that I love, but it is prop medications. And sometimes people get really stuck on that of like, well, this isn't my medication. It's okay that I can't tell you the answer to this because this isn't how I would do it, or this isn't mine, or these aren't real. And so if that's the case, that's not the most appropriate. Sometimes people just need to use their own stuff. They might also make errors with things that aren't theirs that they're not familiar with. And so then you're not necessarily getting quite the information that you need. Some folks feel like they're being tested when it's a structured assessment and you have to read the questions in a certain way, and that can increase anxiety and affect their performance. And it certainly does limit the flexibility. If you want a true score, you can't deviate too much off of what the assessment does. So again, some pros and cons, but if you're getting used to this idea of observation and what that looks like and feeling comfortable with it, sometimes starting with those standardized assessments can feel a little bit easier to build those skills over time. And then the third part about assessing health management is really understanding the environment. Our folks experiencing homelessness really experience a lot of external barriers and environmental barriers to health manage, many of which Kate spoke about at the beginning. So as a provider, it's really important to know what those are, especially if you're based in clinic or in respite where you're not necessarily seeing the person in that space. So we want to make sure that we are visiting at If you can, visit the space where the person is staying or living. So getting to know the shelter spaces or what, encampment spaces look like, or in the respite program, like figuring out permanent supportive housing, like what does it look like? What does the person have access to? How are they having to navigate the space? If you can't go see it in person, talk with the client, ask them to tell about the routines and what it looks like. And like, hey, I don't have a place to put my stuff. So all of my meds have to go in this backpack. And I try to keep it at the top so that I can get to it, but there's not enough time, right? Talking through that process really helps understand like how much time and space and dedication people have with that. And then potentially also talking with staff or providers, like maybe you can't go outside of the clinic, but your outreach workers can. Have them tell you about the space so that you know kind of what people are navigating. And these are just some things to help and understand that context and environment piece around, what is happening with folks and what resources might be available to them. And that goes just beyond the physical space, but, what is their access to supplies? What is their insurance status? Safety needs that they might be prioritizing. So I'm going to turn it over to Kate to talk about what do we do with all of this information.
So we're now going to kind of put it all together. It's a lot of different pieces. And as we said, it's helpful to think about this in kind of a stepwise manner, but many times these might be happening simultaneously. We're doing some of these things together. We might be doing this in a very targeted way because someone is having a particular challenge that we're trying to address. And so the task now for us is to kind of put all these things into place. So what is this kind of holistic clinical picture for this person? We're thinking about what are the strengths that they have, what are the barriers that we've identified, and then what are some of the supports that we could help them with that's going to kind of move things in the direction that we want them to. So perhaps it's adjusting medications and dosing schedules. An example of this that I find happens frequently is someone gets discharged from the hospital. And again, we come back to insulin, I think just because it is a somewhat high risk med and it's confusing and difficult to administer. And oftentimes I see people coming out of the hospital with a very complex insulin regimen. They have fast acting insulin, they have long acting insulin. They're supposed to be checking their sugar before meals and then using a sliding scale. And so it can be really overwhelming. And when we assess this with somebody, we may find it really doesn't make sense for them. And we want to make some adjustments to try to simplify that regimen. Maybe they're going to take an oral medication in the morning and they're going to use a long acting insulin one time at night. And we're going to see how that goes. We may be referring folks for further evaluation. We may see that there's a need for them, let's say, to work with an occupational therapist to kind of try to figure out what's happening in their home space or in the place where they are living, so that we can see what's going on. Connect to community supports. This is another area where we might be trying to kind of bring in some additional resources for someone, access their DME. So thinking about how can we get DME in place that they know how to use, that they're able to use, that they're able to plug in, that they're able to carry with them if necessary, all the things depending on what's happening for this person. Addressing sensory impairments. This can be a big place where we realize that people, may have a deficit that they weren't even aware of, or that is impacting their ability to actually carry out health management skills, providing education and teaching in areas that people need help, and then adjusting the frequency of follow-up visits. So a lot of times with someone, especially if there's a new diagnosis or there's a new challenge that's come up, it really helps to kind of front load those visits if the person is able and can tolerate that, to really kind of get them going in a so that they feel confident. So they may be coming back somewhat frequently at first, and then once they feel confident and can take it over themselves, we can decrease that visit frequency.
All right. So we have a couple of case examples that we can share, but because of looking at the time, I want to make sure that we are able to respond to folks' questions. So please feel free to throw a question into the chat, but also you can use the raise hand feature or, come off mute and ask your question, and we'll take a few moments just to see if there's any questions from anybody before we go into any case examples. All right, I'm not seeing any at this moment. So we'll go ahead and do the case examples. But again, as we're talking through, please feel free again to throw any questions in and we'll address them as we have a moment to. So we have this first case example here with a gentleman who was in a medical respite program who was referred after several toe amputations and recovery from frostbite. So seemed to be relatively clinical case around addressing the amputation and recovery piece there. However, this was an individual who had not been engaging in primary care and in medical respite engaged for the first time in 15 years after experiencing unsheltered homelessness, which identified a chronic heart condition that initially required a lot of frequent changes in the medication dosing. However, this person is someone who had not had any significant health conditions prior in their life and really had limited knowledge of medication management and health management skills. They also had some memory issues that were complicated by ongoing alcohol use. So memory issues outside of the alcohol use, but then, that changed a little bit of the person's function. So what was addressed with this particular person? So there was, teaching and skill building. So really looking at and assessing the person's medication management skills. This was the priority event, and the priority issue. So there was education and teaching for this person around how to refill the prescriptions, how to schedule appointments, kind of those basic health navigation skills, working with him to use the pillow axe to organize medications and also address some of the recall issues, had good day and time awareness. And so it wasn't an issue to be able to use that. The person also started using a notebook just to monitor some symptoms and to build self-awareness around how they were feeling and what they would need to report to the doctor. It also allowed them to write down questions they had for the doctor so that when they went to appointments, they felt prepared and like they could remember what they wanted to ask. And because they were in medical respite, were supported in those appointments with a community health worker who could help advocate and make sure the person had time to ask those questions. They also worked on self-advocacy skills and engagement with providers using a harm reduction approach. And so, making sure the person engaged with the health center, that was really good about that, but making sure that the cardiologist was treating the person despite the fact that they were still using alcohol, and making sure that clinical decisions were made with that person, including that in their daily routine. Now I'm going to turn it over to Kate for our next case example.
Okay, so this example, and again, feel free if folks have questions to put them in the chat. This is a 61-year-old cisgendered Black male who presented to clinic with a foot ulcer. So that's the reason that the person came in. They had a new wound and needed help with it. And then through the course of meeting with the primary care provider and having some lab work done, was found to have uncontrolled diabetes. So this was a new diagnosis and was definitely related to the wound which had not been healing up to that point. So to begin with, this was a new diagnosis. This gentleman had a pretty limited understanding of diabetes in general and how this related to the wound and wound healing. Had not used insulin before. Was staying in shelter and was having a really hard time with storing and accessing medications. This was a shelter that he really didn't want to be in. He was trying to kind of get out into the community as much as possible, and that meant he was missing his midday meds every day, just because he wasn't wanting to kind of be waiting around and taking the meds in shelter. And was also staying in a place where, as in many shelters, it's really difficult if you have a special diet to kind of have control over what you're eating and manage it. So he was having a really tough time with dietary management as well. And it was all new to him. He had not been thinking about eating in terms of diabetes previous to this, so it was difficult. So the teaching and skill building interventions, one was just learning about diabetes, dietary basics. And I want to emphasize that this happened over many weeks. We did not have a single session in which we were like, here's everything you need to know about diabetes. Here's how you use insulin. This is how we're going to do the wound. I mean, this gentleman was very motivated by the wounds. He ended up having a wound on both ankles, and he really did not want those wounds. He wanted them to heal and wanted to do what he needed to do, which was wonderful. He was highly motivated. And so this happened over months of coming into the clinic 2 or 3 times a week for wound care management. And each time we were providing teaching around diabetes and diet. He was learning how to use insulin. We were helping him with short-term supplies of medications and showing him how to fill a med box. So he was becoming more and more independent with managing those medications, with taking his insulin, with understanding how this all worked. And thankfully, because he was able to do this, his wounds did begin to heal. And so that was also highly motivating. He was seeing results from the interventions that he himself was doing, and was seeing that it was making a difference. His blood sugars came down. We did so much celebrating around the, decreasing of his blood sugars and the closing of the wounds. And in the midst of all this, this was a 6-month process. He was able through case management support to get his own housing. And so that launched this whole new kind of phase for him in his self-management and health management around starting to cook for himself and learning how to do that. And so he now comes into the clinic, only once a month. The wounds are both closed, his diabetes is under control, and he, talks very passionately about the impact of diet on health and how he, has turned all these things around. So it has really been a great story to see him kind of build these skills over many, many visits. And I
So
saw Caitlin launch the poll.
yeah, so we are nearing the end of our time here. So just wanted to say thank you to all of you for joining our conversation today. Please complete the poll. That really helps us inform our next steps. And just as a reminder, this is a resource that's coming out with some recommended tools, and really kind of walks through all of these steps that we covered today around the assessment process. So when that is posted, we'll be emailing that out to all of you as registrants from this webinar so that you can find it easily and quickly once we have that posted. We just wanted to note there's a couple of other opportunities for learning coming up over the next month or so that we would love for all of you to join. We have a virtual symposium around trauma-informed design in medical respite care, but really honestly would be great for anybody working in a health center space as well. Kate's going to post the link to the registrations for these. We also have a webinar coming up on April 8th around gender affirming care in medical respite, which is really exciting and sort of a new set of knowledge and resources that we have for the field around providing gender affirming care. And then finally, if you're not already registered, we really hope that we will see you at our national conference May 13th through the 16th in Phoenix, Arizona, an opportunity to continue learning and engaging with others in the field. So with that, I think we can say thank you to everyone. If you have any questions, please don't hesitate to reach out to all of us. We'll be happy to answer any questions and then be on the lookout for the resource when it is published in a couple of weeks, hopefully. So thank you, everybody.
Thank you.